Hello everyone, my name is Dr. Dami Collier and I'm going to be The aim of the session is to review the diagnosis of COVID-19, review some basic epidemiological principles of test accuracy, to provide an overview of near-patient testing and the SAMBA trial that was undertaken here at Edinburgh Hospital, and to review some of the limitations of testing in the current pandemic. You've had the case of a 77-year-old man who presented to the emergency department with a 2-day history of non-productive cough, shortness of breath and fatigue, and a 7-day history of increased frequency of stools. And as part of his diagnostic workup, he's had a SARS CoV-2 swab test. So let's unpack that a little bit. So this is what we commonly refer to as a nose or throat swab, whereby a flexible sterile swab is inserted along the floor of the nasal cavity into the nasopharynx, and that's sampled. And in reality, we do a combined nose and throat swab, and the same swab is then inserted through the mouth and into the oropharynx, which is sampled as well. This is then placed in a vial of viral transport media and then transported to the laboratory, where it then undergoes a nucleic acid amplification test, in this case real-time PCR. So a set of primers which amplify specific regions of the SARS-CoV-2 genome are utilized. In the case of the standard laboratory RT-PCR here at CUH, there are two targets. The primers target two regions of the genome. So the RDRP, so the RNA-dependent polymerase within the RF1B region, and the E gene over there. And by a series of cycles of amplification, the genomic material in this viral transport media from the combined nose and throat swab is amplified onto a point where it can be detected in a PCR machine. And this is what we refer to as the cycle threshold. So each cycle of PCR amplifies the genomic material in the sample onto the point whereby this exceeds a threshold fluorescence level and it's picked up. It's worth noting that the cycle threshold is inversely proportional to the amount of viral genomic and hence viral material in that sample, such that if the cycle threshold is low, it means that the amount of genomic material was amplified in fewer cycles compared to if the cycle threshold is high, which means that more cycles of amplifications need to have been undergone before the sample exceeds this threshold and is detectable. Generally, in the trust, the limit of detection is about 36, and beyond that, we'd call that a negative sample. Below that, we'd say it was a positive sample. And this process takes place in a laboratory because, as you well know, this is a respiratory pathogen. Special precautions have to be taken when it's handled, such that it's the sample needs to be deactivated in a category 3 laboratory under specific conditions, and this obviously creates a bottleneck in processing samples. In addition, because of the limitations with handling this sample in a category 3 laboratory, this is often done in batches, and that can then have a knock-on effect on how quickly samples can be pushed through the pipeline. So this individual then had two swabs, one taken from the nose and throat as I described, which was found to be negative, and then had a subsequent sample from sputum. So this would be a sample that comes from deeper down in the airways, so a deep sample, and this was found to be positive. So it's interesting to note that several studies have looked at at specimens from different locations, and have found that although a combined nose and throat swab is adequate in the vast majority of people, in certain individuals, particularly patients who are immunocompromised, as you know, SARS CoV-2 causes a pneumonitis. The disease may be within their lungs, and they may not have sufficient viral load in their upper airways that could be picked up on a nose or throat swab. And this study, for example, sampled patients within an epidemic in Germany, and this is an example of 9 of those patients. The yellow line shows samples obtained from nose or throat swabs, and the brown line are samples obtained from sputa. And what they demonstrated is in the vast majority of patients, the sample from the sputum remained positive longer, or remained detectable longer than the sample from the nose and throat swab. And in addition, the viral genomic material within those samples was considerably higher in the sputum sample for most of these patients. So I guess the take-home message from that is, in patients in whom you highly suspect disease and in whom you get a negative swab test result first, it is worth requesting a subsequent one or getting a deeper sample, particularly if they are immunocompromised. I mean, it's worth saying also that there are also limitations from nose and throat swabbing, because the test is only as good as the sample that's collected. If, for example, the swab isn't inserted far enough, then you're likely to pick up viral genomic material on the swab, which can then be amplified and tested. So another nucleic acid-based amplification method that's been utilized here is the SAMBA, which stands for Simple Amplification-Based Assay, which utilizes isothermal amplification. Again, this targets 2 regions of the viral genome, this time RDRP, but also the N gene. And the benefit of this is this can be relatively sited, could be near patient sighting with rapid results within 90 minutes. SAMBA platform isn't new. It's been used for many years in sub-Saharan Africa, where it's been used for HIV diagnosis, viral load testing, and hepatitis testing. And so this platform has recently been adopted, modified to diagnose SARS-CoV, to detect SARS-CoV-2. So the COVID-X study was a prospective clinical evaluation study of the diagnostic accuracy of this rapid point-of-care test. Using the SAMBA platform initially, we analyzed its diagnostic accuracy against what I already described, the laboratory standard RT-PCR test. This study was conducted after lockdown, so we had just passed the peak of the epidemic, and we essentially instituted this at the front door, and eligible patients were adults who were being admitted, who fitted the then Public Health England diagnosed definition of a probable COVID case. So they had clinical radiological evidence of pneumonia, were in acute respiratory distress, or had a flu-like upper respiratory tract type illness with a fever. And we evaluated just over 170 of them. 2 swabs were taken in parallel. One was sent to the main lab for standard RT-PCR, and one was conducted on the wards using the SAMBA 2 rapid diagnostic platform. And what we discovered was this test performed, very well, almost as good as the standard testing, with a sensitivity of almost 97% and 100% specificity. Importantly, we're able to overcome some of the bottlenecks that I described earlier with testing in the laboratory. Obviously, given the high demand for COVID-19 testing, capacity, the hospital was at its capacity, and we were able to reduce the turnaround time from taking the sample to being able to deliver the test to patients from 26 hours to 2.6 hours, which is pretty significant if you imagine that the A&E departments and the acute admission units were inundated with patients and needing to move patients along to safe places of care during the peak of the epidemic. At this point, it's worth revising what I mean by sensitivity and specificity. So these are basic epidemiological principles of test accuracy. So here I just demonstrated a simple 2x2 table, individuals who, by a reference or gold standard, in this case the RT-PCR, are diagnosed with COVID-19, and those who don't have the disease. And this is a test under consideration, for example, the SAMBA test. So we do have individuals who we know have disease who are picked up by the test, so true positives, and those who we know have the disease but are not picked up by the test. These are the false negatives. In addition, the people in whom we know they don't have the disease who are falsely called positive, so these are the false positives, and individuals who don't have the disease and are called negative by the test. These are the true negatives. And so sensitivity is defined as the proportion of those in whom we know who have the disease who correctly test positive by our test. And the specificity is the proportion of those we know who don't have the disease who correctly test negative. And other diagnostic characteristics you should be aware of are positive predictive value, which is defined as the proportion of those who have disease who test positive, and the negative predictive value, which is defined as the proportion of those without disease who test negative. And it's worth noting that these two parameters, positive and negative predictive values, are highly dependent on the prevalence of disease. So for example, if the disease prevalence is high, so at the peak of the epidemic, of the COVID-19 epidemic, for example, the positive predictive value is high. So the majority of people you're picking up truly are positive, and you're picking up very few false negatives. As the prevalence reduces, so in the period in which we're in currently with a low prevalence of disease, the positive predictive value then becomes low, such that you're more likely to pick up false positives. The converse is true for the negative predictive value. As the disease prevalence decreases, the negative predictive value becomes higher, and that means you're less likely to pick up false negatives. So I've put a link here, which is a YouTube video that goes through a couple of worked examples really briefly and clearly for you to sort of get your head around these two concepts and the impact of prevalence on both the positive and the negative predictive value, because it does have a bearing on how these tests are interpreted in real-world settings. So another thing that we discovered during the trial was that there were patients in whom we had a very high clinical index of suspicion that they had COVID-19 who were PCR positive, but there were also some patients in whom we were pretty sure had COVID-19 and whom were PCR negative. A lot of these patients went on to have repeat testing, but were consistently negative. And we now have come to understand that in possibly 30 or more percent of patients in whom we know have COVID-19, the PCR test is negative. And this is a graph from another paper who looked at just over 100 patients and looked at their household transmissions, and they tracked the cycle threshold almost daily in these people to try and put a quantitative value on the amount of viral burden over time. And what they did show is that even by about 7 days post-infection, cycle thresholds were at the limit of detection for most assays, so over 35. And so you can imagine if these individuals are presenting to hospital, which is when we tend to see patients with the respiratory distress and being quite unwell and requiring hospital admission, they often present 7 days or more into their illness. And you can imagine at this point, if we then apply our PCR test, no matter how deep or how good the swab is that's taken, PCR is not going to pick these people up. However, they still have COVID disease. And what's clear now is that the COVID illness is in two phases. There's the initial virological response to the disease, where there's viral replication in the upper respiratory tract, and people have an easily identifiable flu-like illness. And then this leads on to the second phase of illness, which is now thought to be immunologically driven, and which is characterized by an exaggerated and unregulated immune response to COVID-19. And this is generally where we're seeing patients presenting to hospital, requiring respiratory support, and so on. And so this led on to the second phase of the study, in a bid to diagnose these patients in whom we were, the clinical index of suspicion for COVID disease was very high, but in whom the PCR testing was negative. And so we employed antibody testing in these individuals, initially using the antibody test on its own to see how good it was, and then combining it with the SAMBA PCR test that I've already described. So this is very simple, like comparable to a blood glucose test. So a pinprick, a finger prick blood sample is obtained, which is then put onto the test strip with a proprietary buffer, and then read out in 10 to 15 minutes on this lateral flow, immunochromographic lateral flow assay. You get a band here for the control line to show that the test has worked, and then an IgG or IgM band, depending on what phase of the illness the individual is in. So this is an example from one of the patients in the trial in whom we obtained serial blood serum samples on these days since presentation. And the first test that was done, you can see a faint IgM line, which you would expect at the onset of illness, and then this is then converted to IgG, and then over time the IgG band becomes more intense, and we've presented this graphically as well. So the IgM's peaking early on in disease, followed by the IgG, which then begins to rise over 2 weeks of illness. And what we were able to demonstrate was, as expected, the PCR-based tests, so the SAMBA in this case, performed very well early in disease with 100% sensitivity and specificity. But as illness duration got longer, so people coming to hospital in the second week and the third week, unsurprisingly, based on the graph I showed you earlier, we're not picking up viral genomic material from nose and throat swabs, so the sensitivity goes down, but the specificity remains very high. We then applied the point of care antibody testing to these same individuals and showed that actually the sensitivity, although high early in disease for this test, not so high in this other test, which is called short screen. But as time went on, as you would expect, the body has had time to mount an immune response to the virus. The sensitivity goes up, and overall, if you take all patients in whom you have a high clinical suspicion of COVID-19, the overall sensitivity was 79% with specificity of 100, with using a PCR-based method on its own. But if done in combination with an antibody test, we're able to get our sensitivity up to 100%, in this case with the COVID-X IgG-IgM test, and in this case with the short screen IgG-IgM test. One test is obviously better than the other. This one has a lower sensitivity than this one, which means that in this test is actually pretty good. In combination with the SAMBA test, we have a false positivity rate of just over 5%. There are a couple of other things I just wanted to say in the sort of wider context of testing, particularly as lockdown has been eased now, and obviously the relative opening of society. There is a trade-off between sort of highly accurate, expensive, centralized lab-based testing like RT-PCR, and less accurate but cheaper tests that are being talked about these days. One example would be antigen-based testing. This is because, as I pointed out already, as the duration of illness progresses, the viral burden in the upper airways decreases. And this other study from the same paper showed the peak infectiousness. So what we do understand now is that people are probably at their most infectious just before they start to show symptoms, and so they've been shedding virus all this while. They then start to have symptoms, and then the viral load in their upper airway begins to wane almost as quickly as it went up. What's interesting to note from this other study that looked at the outbreak in Germany is actually if you try to grow the virus from people after they become symptomatic, so 4 days, 6 days, 8 days, very quickly, the proportion of people in whom you can grow virus drops precipitously. So, a week into illness, less than 50% of people, you're actually able to culture virus, which would suggest to me that if we could actually deploy tests more widely to both symptomatic and asymptomatic people, we hopefully could pick people up when the viral loads are very high at this point, in order to prevent onward transmission of infection. So key learning points are NAT detection of SARS CoV-2 is highly sensitive and specific. RT-PCR can be expensive and time consuming, but may be overcome by rapid diagnostic testing. And remember that test performance is related to the prevalence of disease in the population. A couple of references for you to look up. So this BMJ article goes through interpreting COVID-19 testing and into more detail in some of the things I've touched on. So limitations of nose and throat swab testing, the impact of pre-test and post-test of pre-test probability and disease prevalence. And this is the reference for the SAMBA trial that I've discussed at length. Many thanks for listening.